I'm going to reprise a presentation I gave last fall at TCT on the primary results of the 12-month Imperial randomized trial. My disclosures. And the investigators. And I do this talk on behalf of all the investigators who did a spectacular job of not only recruiting but also getting complete data. So we know that DES and DCBs improve the patency and reintervention rates versus older endovascular therapies without paclitaxel. But interestingly, there have been no powered head-to-head comparisons from the same treatment class in a large-scale, independent, controlled way. Clinical study comparisons typically use conventional PTA versus control, typically use their active device versus PTA control. And because of that, we have a continuous debate because we don't know what to do on a head-to-head basis, and there's not a lot of randomized trials around this. So the question is, does a drug-eluting stent with sustained release improve patency over the existing drug delivery stent vehicle? So to answer that question, the Imperial randomized control trial was developed. The clinical trial overview is here. I was privileged to be the PI with Stefan Müller-Holzbach. The randomized control trial, which I'm going to elucidate here, was a 2-to-1 randomized design with a single blind and non-inferiority with a post-hoc pre-specified superiority analysis built into the statistical plan. 465 patients were enrolled, 309 in Eluvia and 156 in the Zilver PTX. There were 2 other studies, a long lesion substudy, a totally separate group of patients, 50 non-randomized patients, and a pharmacologic or PK study looking at dosing and plasma levels. That was done at some selected sites. Investigational centers were really all over the world, so this does represent a global study. I'll be talking about the long lesion study later on today. So as we look at the endpoints, the primary effectiveness endpoint for this trial was the primary vessel patency as assessed by duplex ultrasound at 12 months post-procedure and adjudicated by an independent core lab. The non-inferiority margin was set as 10%, and for the primary safety endpoint, there was major adverse events, which was all-cause death through 1 month, target limb amputation through 12 months, target lesion revascularization through 12 months, which is considered a safety endpoint by the FDA because of repeat intervention and risk. And again, a 10% non-inferiority margin was chosen there. The inclusion criteria, the key inclusion criteria here is basically a claudicant class of patients, lesions in the native SFA or proximal popliteal artery. This lesion had to be at least 70% or greater by visual angiographic estimate at the site operator. The vessel diameter had to be between 4 and 6 millimeters, and the total lesion length was limited to between 30 and 140 millimeters. Again, I'll go through the long lesion subset later on today. The exclusion criterion, the vessel could not have been previously treated with a drug-coated balloon in the prior 12 months or previously stented. Prior surgery was excluded, and the use of debulking or other specialty devices was excluded. Patients on dialysis or end-stage renal failure were excluded. Here are the 2 devices, and just briefly, I think most folks know about this, but the real difference between these devices, they're both nitinol-based, and they both have paclitaxel on them, although the dosing is somewhat different. The real difference lies in the polymeric coating of the Eluvia stent, which has been used in the Promise coronary stent for tens of thousands of study patients and millions of actual clinical deliveries. This is a fluorinated polymer which has been shown to be exceptionally safe, non-thrombotic, and actually as compared to prior iterations of classes or generations of drug-eluting stents in the coronaries, as well as bare metal stents, is shown to be superior. In the Zilver PTX, there is no eluting polymer, so the payload of paclitaxel is delivered immediately, and you'll see in the next slide that results in a different PK curve. So, as I promised you, the Zilver PTX curve of paclitaxel concentration in the tissue actually is quite large at the beginning, payload is dumped, and then drops fairly significantly after 60 to 90 days. as opposed to Eluvia, which was purpose-built to elute longer, frankly, over the course of a year, which matches the restenosis timeline, which tends to peak between 10 or 12 months in the SFA. And when we look at the OCT and histology at 90 days, we see that, at least in the animal, there seems to be effectiveness in this strategy of longer-term elution as managed by a polymeric elution profile. So back to the trial. 852 patients were screened. In this consort diagram, you can see that 328 were found to be eligible. The 50 in the sub-study, ineligible, 50 were siphoned off to the sub-study, leaving 465 patients who were randomly assigned 2-to-1 to either Eluvia or Zilver PTX. Very little loss to follow-up or withdrawal or death. And you can see here that in the full cohort analysis, we now have near 294 patients and 146 patients respectively. This is the baseline patient characteristics of each arm, and you can see there's really no differences between the two arms. And if we look at the distribution by ancestry, you can see there's no differences here either. The baseline lesion characteristics were not different, but they're worthwhile pointing out that the lesion length was approximately 8.5 centimeters for both arms. There was interestingly moderate to severe calcification in over 2/3 of the patients in both arms, and there were CTOs in about 1/3 of the patients, as this was not excluded by protocol. So a relatively representative lesion set, not the simplest and not the most complex. If we look at primary patency at 12 months, we see that as established by the non-inferior endpoint, it was achieved. Eluvia had a primary patency of 86.8 versus 77.5 in the Zilver PTX with almost a 10% delta at 1 year. The post-hoc superiority analysis was then invoked as per the pre-planned analysis, and you can see the superiority was also met according to the analysis. So we now have a superiority signal within this trial. And looking at this in a Kaplan-Meier analysis graphically, you can see that Eluvia holds up a 10% advantage over Zilver PTX. If we look at the safety outcomes, there was interestingly about 50% less stent thrombosis in the Eluvia versus Zilver PTX. Not really clear why that is, and there was also noted 6 cases of what was termed positive remodeling with the Eluvia, about 2.1%. 6 lesions, all these 6 lesions were patent at 1 year, and none were associated with stent thrombosis, TLR, or stent fracture. In fact, stent fracture was exceptionally low in both arms. If we look at the clinical outcomes, which is most important to the patient and payer, ABIs from baseline to 12 months improved significantly. They improved equally between the two, but there were twice the number of interventions required in the Zilver PTX to achieve the same clinical outcome. Same is true with walking impairment questionnaire. If we look at the Rutherford class distributions, we see that there was a marked improvement between baseline and 1 month, and this was maintained out to 12 months. So in summary, the primary non-inferiority, effectiveness, and safety endpoints were met in the Imperial Global Randomized Controlled Trial. There was also a superiority primary patency achieved with Eluvia versus Zilver PTX with a roughly 9 to 10% delta at 12 months. There was a marked trend toward lower clinically driven TLR. I didn't point it out, but the TLR at 1 year was 4.5% for Eluvia and 9% for Zilver. For Eluvia, that's approaching coronary style TLR rates. And there was a higher rate of stent thrombosis for Eluvia versus Zilver PTX, although not statistically significant. Significant symptomatic, functional, and hemodynamic improvement through 1 year in both groups was noted, but with half the revascularization rate for Eluvia. I'm proud to say that we were able to have this published in The Lancet as a concurrent publication with the original presentation. Thank you very much.